that Dr. Redmond isn't here, because I was going to do a short homage to him while he's still amongst the living. And well, you know, it's great to talk about somebody when they're in a box in a corner, but it's nice if that person knows that someone thought something about it. That's good.
This is the video recording of that.
That's good, because I really thought about this since last year. When I was a young fella at Columbia and decided I wanted to go into maternal fetal medicine, I wanted to be what I used to call a shepherd, and I wanted to do physiological research involving sheep. And there was a pretty good place at Oxford doing it, at the Newfield Institute. And Stan James was the director of neonatology at Columbia at that time, and he wanted me to either go to the Nuffield and work with Sir Geoffrey, or to go to San Francisco and work with Heyman and Rudolph. My wife would have gone to San Francisco, but she wouldn't go to London. We had two small children, and she thought we'd live in a stone house with moss grown on the inside of the building, and we'd be eating overcooked potatoes and soup all the time. Now, she's an Italian person. She likes tomatoes and warm weather and sunshine. You know, the Italian God is the New Testament God. He's merciful. And the English and Irish God is the Old Testament God. He is just, he is jealous, and he's vindictive. So, and I was raised in that environment. She was raised in the other one. In any event, we didn't get to Oxford until at the last meeting. So, Dr. Redmond, somewhere in my training, I had a patient who was a patient of Dr. Redmond's, and I had no idea who the guy was. And my patient was a midwife. Her husband was a surgeon, and they had been at Oxford, and then now we're at Columbia. They were from Nigeria, and she came with her records to one of our senior obstetricians. She had significant hypertension, and in a prior pregnancy, she had been treated by Dr. Redmond, who followed her. And I was really surprised, because at that time in North America, we were afraid to use anything but, you know, chlorothiazide diuretics to control hypertension. And here was Aldamet, you know, and we were afraid of Aldamet because it's a neurotransmitter, and we didn't know what the pharmacokinetics were like, and what effect it would have on the baby, and what effects it would have on the uteroplacental circulation. So, but she did well, and I'm seeing her at 36 weeks of pregnancy. She had done well. And I always remember that woman's name. And then I read a paper in 1976 about fetal outcome and trial of antihypertensive treatment in pregnancy. And this was at an era where we were still pretty much focused on clinically, even at a big institution like Columbia, we were still focused on the mother and the global outcome of the pregnancy. We weren't so concerned about this monitor, this test, this approach to that, because we realized that a lot of that was still quite investigational. And I was impressed by the fact that this was a randomized trial done on a bunch of pregnant women, because it's really hard to get IRBs to approve randomized controlled trials in pregnant women, at least in North America, which is where I was. So I was thrilled to just go back to the first page and reminded, that's all right, that in the May journal, the May issue of the American Journal of OBGYN, Dr. Redmond was feted as one of the giants of obstetrics and gynecology by a prominent academic obstetrician in North America called Roberto Romero. And that to me was kind of nice. And I knew I was going to see him here. And I want to say, well, you know, back at my side of the Atlantic, they think an awful lot of you. And I personally think an awful lot of you because of the randomized trial you did on this very nice lady that I happened to take care of 40 years ago. So that's the first part of my talk. Second part of my talk is a little bit different, but it's a light skip through a shallow pond. And this is for the engineers in the audience. It's the obstetricians, you're going to be bored to death. This is simple stuff, but I was instructed by Her Highness, right? And you got the same missive. Pretend you're talking to a bunch of 10-year-old kids. Keep the words simple. Keep the jargon low. And we poor old country obstetricians have had to listen to all this electrical engineering and computer science. So I'm going to subject the engineers to a little bit of obstetrics, because we so frequently as obstetricians get maligned by people from other disciplines. So, and I'm going to start with this book. This is a great book. It's by Ken Follett. It's a novel. It's called The Pillars of the Earth. And I read this as an adult, not as a young child. And the first chapter of the book is so moving. The big story is about this guy who's a stonemason. He's looking for work. And he hears that the next town over, or the next shire over, they're going to build a grand cathedral adjacent to a monastery. They got an endowment from somebody. And so he's walking down this dirt road, and he has a pregnant wife who's near term and 2 young children. And they're walking down the road to get to this shire, and he hopes he can get a job. And she goes, they make camp for the, she starts cramping, and so he said, well, we better make camp for the night. And they walk over the side of the road. His major concern at that time are bandits hiding in the woods. But he makes a camp, starts a fire, sets up some kind of a shelter. She goes into labor. He shoos the kids out of the way. He's the midwife. And he delivers the child, delivers the placenta. The uterus doesn't contract. And she dies. She exsanguinates right there on the spot with her 2 kids sitting out there. This normal, beautiful term baby. And she's dead. And he has to go outside and dig a shallow grave to bury his wife so the wolves don't eat her carcass. This is like the 13th century. Right? And when he gets done with that, he looks at this baby. And he realizes he can't feed this baby and that this baby is going to die. And there's nothing he can do about that. There's no source of nutrition for this baby. And he takes this baby up into the woods where there's a big rock, and he puts the baby up on the rock so it can be have a quick death at the hands of large birds and wolves. Comes down the bottom, gets the kids, and walks on down the road to this town to look for a job. And I read this and I go, Jesus Christ. You know, this is an awful story. But it was a very common, altogether too common story. Still is in many parts of the world, but certainly not in England, you know. And I was moved as an adult man and the father of kids. And I want you all know, all of you engineers, to know that that was the time when the outcome of a pregnancy was that the mother survived it. And if you had a child at the end of that, that was a bonus. That was a bonus. You were lucky, very fortunate person. And in the United States, I might add, most of the people that signed the Declaration of Independence back in 1776 were widowers, and their first wives all had died in childbirth. And that wasn't that long ago. That's a couple hundred years ago. So, we got a little bit smarter. We got a little bit better. We learned about germs in the 19th century. And we learned about herbs that make the uterus contract in the 19th century. And so one big major killer of pregnant women, hemorrhage, was diminished significantly. And that's a major public health event that nobody cares about because it was women, you know? You know how that goes. So slowly, we progressed in the field of obstetrics. In the late 19th century, Cesarean sections were not done. And Cesarean sections were not done because universally the mother died in the process of doing the Cesarean section. And why did she have to die? Well, it was an agonal procedure. If there was an obstructed labor and she wasn't going to deliver, and if she was having a fever, you know, you had to empty that uterus and make it contract. So it was truly an agonal procedure. And at the Presbyterian Hospital in the city of New York, one of the citadels of North America, I had the honor of reading some dictated operative notes from the turn of the 19th and 20th century. And when a woman was going to have a section, they rang a bell. It was the Sloan Hospital for Women. They rang a bell, and that was a signal for this chief resident. Barry, you know these stories, right? It was the chief resident, and, well, he was the resident. the chief of the obstetrical service and the chairman of the department did the surgery. There was no anesthetist. There was no pediatricians. They did the section. And in general, skin to skin, the operation was completed in less than 10 minutes. And it had to be that way because the head nurse was given open cone ether, and it was hard to keep the patient alive but deep enough to be still while the procedure was being done. In 1920, there was in 1976, I read a book that was a centennial homage to the performance of the first cesarean section, and it was done in deliberate, where the woman wasn't agonal, and it was called a Perot hysterectomy, a Perot cesarean section, and the greats of obstetrics went in and wrote articles of various aspects of cesarean section, and one was a history of cesarean section in North America. And the guy said that there was absolutely, and he said this was published in 1926. I'm reading it in this 1976 book, that there is no indication for performing a cesarean section on an indigent woman because she's going to die. So the mortality rate for cesarean section in an indigent population was like 23%. That's pretty high when you think about it. 23% for cesarean section. Today, it's less than 1% for coronary bypass surgery, So cesarean section was not a procedure that was taken lightly. So in that same era, everybody was inventing forceps. Because, we were still in the mindset that, well, we got to get the mother through this and be alive. And if we get a live baby, it's a bonus. So there's Tarnier forceps. And there's Barry and I, we didn't overlap in our training. But I spent all of my residency, he spent part of his residency at Presbyterian Hospital, the Sloan Hospital for Women, and they had a large cabinet in there, and there were 70 different varieties of obstetrical forceps designed for various conditions that mandated this form of forceps to more safely deliver the baby, not to minimize trauma to the baby, but to minimize lacerations to the mother in the process of the delivery. And that was true up until probably the late 1930s. And outside of obstetrics, we learned about IV fluids and electrolytes. We learned about endotracheal anesthesia came late. But we were beginning to develop blood banks and so forth. And so now surgery in general was safer. So cesarean sections became a little bit more common, but it wasn't until the 1940s, after the Second World War. It's penicillin. It was good blood banking. It was endotracheal anesthesia, so you didn't aspirate and die from open tube. Open ether and an open mouth. And the cesarean section rate was 5%. All right? By the time we trained, and we're old men now, but by the time we trained, the cesarean section rate on a service was about 10%, 12%. Today, in my country, it's 40%, and on Long Island, where we are, it's near 50%. All right? And people want to blame it on the monitor, but it's the sociology of medicine has changed. It's much more transactional, and it's thought to be, having a baby is kind of like getting your tooth pulled. So, but it started in 1958 with the invention of the electronic fetal monitor. Was the real beginning of looking at the fetus as a patient. And in fact, physicians are so conservative. This is a Pinard fetoscope, and the bell goes on the mother's abdomen. This goes to the accoucheur's ear, and you can hear the fetal heart rate. And when that came out, people said, "What the hell do you want that for?" Well, we can hear the baby's heartbeat. So what? It's either there or it's not. And is that a branch point on an algorithm for treating her? So and it was considered to be culturally, theologically, philosophically intrusive and invasive. It took a long time for using a fetoscope to become acceptable part of obstetrical practice, and of course it was improved upon. So, but if I can make this thing, I'm going backwards now. So this is a better version of it. This is the metal. It's the same idea. It's a stethoscope with a bell on the end of it, which is low pitched, so it hears the fetal heart rate better. But the addition to this was a metal stem that goes on the accouchere's head, so you can also recruit bone conduction of sound, so that the vibration of the baby's heartbeat can be carried. Sound more solid the material, the more pure the sound is, and so it can run up that solid bar and get to the accouchere's forehead. So that was the next step. All right. Now, and so it goes. But the biggest and probably the most important thing, and the best story in obstetrics that has to do with a fetus, all right, was what came in the late '60s. And there was a group in Liverpool, Finn and Clark, and there was a group at Columbia. It was Freda and Gorman and a guy that with one of the drug companies, Ortho, over in New Jersey by the name of, it's a P word, Pollock. And they took different paths and erected slightly different hypotheses, but they were the ones that promulgated the first screening test in obstetrics that was designed for the fetus to improve fetal health, and that was to screen mom's blood for Rh positive versus Rh negative, which was only first described in the late 1920s. And then they went through a process where they had the screening test really did work, and that and then out of that they developed what Rhesus immune globulin. So what you did was you took people that were high titer individuals for the Rhesus antigen and a Rhesus antibody, and purified that in separation columns and injected it into mothers and actually prevented Rh disease. And that's a significant thing because 15% of the population is Rh negative, but 85% of the fathers are going to be Rh positive. And so there's a high risk. So the first requirement of a good screening test is that there's a burden of disease. I'm going to skip this stuff. That there's a significant burden of disease. So if you have a large population of women that are at risk for Rh disease and their babies get it, and then every time they have another baby, the disease is worse, it occurs earlier, and it's a more morbid condition for the fetus. And in fact, the fetus can be stillborn. And back in the day, in the Jewish community and the Catholic community, there were big families. So this was a big issue in like the neighborhood I grew up in. They were all Irish Catholics. And we all knew somebody who had a baby that had the yellow jaundice and died, So there was a significant burden of disease, and that's what Rh represented at that time, but it holds for any kind of screening test. The second was that there was an appropriate test that was available, and those were things that were being done by hematologists. So they had an appropriate test. The test was accurate, it was highly sensitive, and it was reliable. The test was inexpensive. It was acceptable to the patient and to the physician, the professional community. And there was effective treatment available. That was the Rogaine. And that all occurred over and it was this great race between Liverpool and New York to see who will be going to be the first people to bring this test to market. But it was a concerted effort. Like, I don't know that much about Finn and Clark, but over in New York, because I was trained, we had Fred was our attending. He wasn't even a scientist. Frankly, he wasn't that good an obstetrician gynecologist. But he's an Italian guy. He realized, he appreciated the burden of disease in his ethnic community. And he worked with an academic pathologist who ran the blood bank at Presbyterian Hospital. and a separation science expert in pharmacology across the river, across the Hudson River in New Jersey, and that was Pollock. It was a multidisciplinary, 3 very different backgrounds of people, and they were quite constructive and successful. And from the day they started the first studies, which was in the early mid-50s, that product, Rogam, was licensed by the FDA and available for use in 1968. And as I said, it was very affordable. So this is a major success, but it demonstrated a real effort to look at the fetus as a patient. If the fetus was affected, there were diagnostic invasive tests that had to be performed, but they were okay because they were not screening tests; they were diagnostic tests. So the risk is higher, but the population is more refined. They are the ones that are at real risk. Okay, so he said, "What is he talking about?" Well, you know, it's the end of the meeting, and I didn't want to get too deep into stuff. But I do want to say that it's real important for all of you engineers and IT guys to stop making fun of the obstetricians. All right, we work hard. You work hard. We went to school. You went to school. We're just coming at this from a different direction, and we need to continue to understand, at least at a sophisticated layman's level, what the other person is doing, and be willing to work hand in glove with them to move this whole process together. And what we need is not just a machine, all right, but we need clinical information and the machine to get us on the road. Because I'm sorry, but present commercially available electronic fetal monitors are not good screening tests for anything. I'm still not sure what the outcome is that we're trying to make this appear by using a monitor. It doesn't affect infant mortality in large populations. It doesn't do anything, but its use is at least associated with a rising cesarean section rate. I'm not going to say that all of the rising cesarean section rate is because we monitor women and we get scared and we section them, but it is a major contributor to that. And there is morbidity, serious morbidity can occur from doing cesarean sections on laboring patients. Now, last year, using the CHECK database, we were given homework because I know I did it, and Peter and I, we did it together. And we're looking at these tracings, and some of them were moderately abnormal, some of them were disgusting, and some were reasonably normal. But they all had uterine umbilical artery pHs attached to them, and the tracings represented the last 2 hours of labor before delivery, and we were asked to predict what the outcome of the pregnancy was. Well, you know, that's not real. That's not how it's done. But we did it anyhow because, you know, physicians are pleasers. And so we wanted to please the engineers. And there was a fight in this room. Who was there at Oxford? There was a fight there. I got choked by Barry. Okay? And he's proud of it. And it was, I think of it as kind of like a good-natured barroom brawl. We were having a great time doing it. It was very animated. It was very loud, and the conference organization, the Congress organizer, was convinced that this was an abject failure, and why did I ever think of doing this? But I think it's helped move us along because engineers were looking at those tracings too because they knew what the parameters were. But what none of us had were clinical data. And the clinical data is what we need to have if we're going to improve our ability to prognosticate an outcome of a pregnancy, or at least better define the abnormal. We need to first identify the outcomes of pregnancy that might be affected by good interpretation of the monitor. But we believe, and Peter's talked a little bit in his talk that preceded me, that we believe that if we're going to go anywhere, we have to take the monitor as one slice of the pie. And we have to take computer interpretation. Maybe there's intrinsic changes in the tracing itself that we can't see, but the machine can see. But we have to take all of that clinical information, patient's age, comorbid conditions. The one group that's starting to do a little bit of that is a group that Barry works with, and they have a thing that they call the Fetal Reserve Index, and it's like a first step. But what it needs to be is automated. The clinical data has to be integrated into the monitor so that in a real-time basis, the machine is taking the clinical data that's available. Most of it is static. It isn't changing moment to moment, but there are physical characteristics of the mother that change during the labor. And we need to couple that with the tracing. And in a perfect world, you want to do the real deep learning, unsupervised. This is my dream. I won't be around to see it. But you want to have unsupervised deep learning. So you don't have a hypothesis. You just take the best tracing you can get and the best clinical data you can and put it in the pot. And it'll tell you if Mrs. Jones, not the diabetics, not the hypertensives, but Mrs. Jones, is she at risk, given this clinical data and that heart rate tracing, is her fetus at risk for an abnormal neurological outcome? And thanks for listening to me ramble. I sprained my leg. I haven't been sleeping well the last 2 nights, but that's my problem, not yours. But thanks for listening to me, and I'll see you in 2 years someplace.
Hear some comments or thoughts? I'm
sure.
But you can sit down if you want.
That's what I want to do.
Who wants to have the final word? I know you have something. Do something. Maybe do. No. I think Austin. You have the last word.
No, fair enough. Gerald, I thought that was a really masterful tour of development of fetal monitoring and obstetrics. Huge congratulations. I have to say, though, that it would be fair to say that intrapartum fetal monitoring has done a lot to almost eliminate intrapartum deaths. I do agree that it does have its downsides, and I totally agree with you that it's not a good screening, never mind a diagnostic test. And I think as a group, we should resist the temptation to make it more complex than it currently is. And I think just to reflect on a small part of that, you might have seen some of Tamaoki's, classifications, which scientifically is fantastic to look at. But actually, intuitively and at a practice level, it is truly daunting. I had the privilege of meeting Julian Perret just a few months before he passed away. And he approached me, having looked at my second whinging paper, where I crystallized what the questions were asking into those 2 comments I put on the board on the screen yesterday. But he still managed to produce 5-tier classification from those two. But then they also went on, and that goes on in Japan, Tamariki will agree with this, to use that as a template for monitoring. So I think for a meeting like this, one of the things that us clinicians can contribute is to be able to crystallize our thoughts into the most simple, basic form that can then be digitized. Now, the first time you and I met 6 years ago, my very first request was, is it possible to digitize what the fetus is trying to tell us on the electronic fetal monitoring? And we've gone back and forth trying to develop that process. It still hasn't happened, but my hope is that at some point it will happen. Because if we can keep it simple, then it becomes doable as far as the technical team is concerned, and our patients will benefit. But I thoroughly enjoyed your reflections, and thank you once again.
I think what's nice about the things we're doing now is we have both computer power and more individuals interested in using that power on this problem. I'm not going to consider well, yes, I am. My wife tells me that I'm a okay feminist, but I think that fundamental women's health care and reproductive processes have not been a priority, and they are becoming more of a priority at a time when there are technologies to do computerized signal analysis and bundle that with the IT systems, the patient's record, right? Cal Hobel and people like that were trying to do risk-based systems off a paper record, 40 years ago. And now it could be done. And now the big in our country, I know, I'm sure it's here too, is that what Centricity, which is GE's product, and the product that unfortunately we have at my hospital, which I don't care for the medical record part, but it's Cerner, and they have a product called Fetal that's integrated into that. There is the possibility of melding them without having to have two freestanding databases for which you have to construct a separate interface, So, in fact, we have a very strong IT group working with us. The fellow in our group that's the IT expert is a senior guy with a ton of energy, and 25 young graduate students who are masters in computer science, who all eventually want to work for a bank, but they have to write their master's thesis. So he has them all working on various aspects of developing the IT support for this. So we think that we've got as good a shot as anybody at doing what you suggest and what we want to do and making a difference. We're not going to solve the problem in 3 years, but hopefully we've got enough progress so that we can get our next competitive renewal from NIH.